Thank you to our major sponsors: Conjugate Corporation, Distrofil, Distribution Solutions Philippines Incorporated, Johnson's & Johnson's Philippines, Lundbeck Philippines, MedChoice, CNS Pharma Group, Medicam, the CNS subsidiary of Unilab, Otsuka Pharmaceuticals, Torrent Pharma Philippines, we would also like to thank our minor sponsors: Abbott Laboratories, Sun Pharma Philippines, Zydus Neurosciences. Special thanks to Vexa Life Sciences. This event is powered by Beatrice. Thank you to our major sponsors: Conjugate Corporation, Distrofil, Distribution Solutions Philippines Incorporated, Johnson's & Johnson's Philippines, Lundbeck Philippines, MedChoice, CNS Pharma Group, Medicam, the CNS subsidiary of Unilab, Otsuka Pharmaceuticals, Torrent Pharma Philippines, we would also like to thank our minor sponsors: Abbott Laboratories, Sun Pharma Philippines, Zydus Neurosciences. Special thanks to Vexa Life Sciences. This event is powered by Beatrice. Thank you to our major sponsors: Conjugate Corporation, Distrofil, Distribution Solutions Philippines Incorporated, Johnson's & Johnson's Philippines, Lundbeck Philippines, MedChoice, CNS Pharma Group, Medicam, the CNS subsidiary of Unilab, Otsuka Pharmaceuticals, Torrent Pharma Philippines. We would also like to thank our minor sponsors:
Abbott Laboratories, Sun Pharma Philippines,
Zydus Neurosciences. Special thanks to Vexa Life Sciences. This event is powered by Beatrice. Thank you to our major sponsors: Conjugate Corporation, Distrofil Distribution Solutions Philippines Incorporated, Johnson's & Johnson's Philippines, Lundbeck Philippines, MedChoice CNS Pharma Group, Medicam, the CNS subsidiary of Unilab, Otsuka Pharmaceuticals, Torrent Pharma Philippines. We would also like to thank our minor sponsors:
Abbott Laboratories, Sun Pharma Philippines,
Zydus Neurosciences. Special thanks to Vexa Life Sciences. This event is powered by Beatrice. Thank you to our major sponsors: Conjugate Corporation, Distrofil Distribution Solutions Philippines Incorporated, Johnson's & Johnson's Philippines, Lundbeck Philippines, MedChoice CNS Pharma Group, Medicam, the CNS subsidiary of Unilab, Otsuka Pharmaceuticals, Torrent Pharma Philippines. We would also like to thank our minor sponsors:
Abbott Laboratories, Sun Pharma Philippines,
Zydus Neurosciences. Special thanks to Vexa Life Sciences. This event is powered by Beatrice.
Good morning, everyone. Welcome to the Makati Medical Center's section of Psychiatry 20th postgraduate course and third webinar series entitled Bridging Mental Health, the Pursuit of Well-Being. I am Dr. Alexa Kiat, and I will be moderating today's session. For this webinar series, we aim to promote the importance of mental health through a series of lectures focused on the mind-body connection and its significance to our overall well-being. Today, our speakers will be focusing on pain and how it impacts our mental health. We are excited to be having this webinar series with the help of our pharmaceutical sponsors and all those who made this event possible. We would like to thank our major sponsors for today, Otsuka Pharmaceutical Incorporated, Conjugate Corporation, and Torrent Pharmaceuticals. We would also like to thank Medicam Pharmaceuticals Incorporated for graciously providing us today's accommodation for this event. Before we officially start, we would like to announce the recording of yesterday's lectures are now uploaded in our YouTube and Facebook page, Makati Med Psychiatry. You may also see the links to the evaluation forms of the past lectures posted on our Facebook page. Now let us remind the audience of our house rules. To officially open today's webinar, let us welcome our Chief of Section, Dr. John Edward B. Hurilla, for the opening remarks.
Welcome to the third day of our webinar series on mental health entitled Bridging Mental Health, the Pursuit of Well-Being. Yesterday, we learned how our behavior affects our physical health. Today, we will be discussing something familiar to all of us, pain. Our speakers, neurologist and pain specialist Dr. Henry Liu and our own psychiatrist Dr. Samaniego, will teach us various strategies to handle pain and distress and how they affect our lives. We hope that these two lectures would allow you to learn new and innovative ways of helping others understand and deal with different types of pain. We would like to thank today's sponsors, Otsuka, Torrent, and Conjugate, for generously supporting today's event. Thank you as well to everyone for joining us, and we hope you continue to do so every day until Friday. Keep safe and enjoy the lectures today.
Our first speaker for today is one of our consultant neurologists in Makati Medical Center. Dr. Liu graduated with a degree in Bachelor of Science in Medical Technology from Veles College in Cebu City. He then took up medicine in the Cebu Institute of Medicine and had his postgraduate internship in Chinese General Hospital and Medical Center. He proceeded to take his residency training in internal medicine in New York Hospital Medical Center of Queens, Flushing in Queens, New York City. He also completed his residency in neurology at New York University Medical Center and his fellowship in pain and palliative care at the Memorial Sloan Kettering Cancer Center in New York. He is board certified in the American Board of Psychiatry and Neurology and diplomate in the Philippine Board of Pain Medicine. Dr. Liu is the past president of the Pain Society of the Philippines. He is currently an active consultant at St. Luke's Medical Center Global City, Makati Medical Center, and Asian Hospital and Medical Center. Let us all give a warm welcome to Dr. Henry Liu.
Thank you very much, Alex, for the very nice introduction. It's a beautiful Wednesday morning. It's my honor and privilege to be invited as one of the speakers for this webinar series of the Section of Psychiatry, Department of Neurosciences of Makati Medical. I'm being given a task to talk to you about pain and palliative care for the next 45 minutes. So the first half will talk about pain and the second half will talk about palliative care. I promised myself that I'm going to make it very light and very clinical, so you can get some salient points that can help you in your clinical practice. So when we talk about pain, we always think pain is something very negative, so it has a very bad connotations. But in reality, pain has protective function. It allows us to seek medical attention if we feel pain. It allows us not to do physical activities that can be traumatizing and painful, and So as a matter of fact, there's a genetically inherited disease where patients will not have pain and they die very early in life, literally traumatizing themselves to death.
There are many rare diseases in the world, A 12-year-old girl, Ashlyn Blocker, suffers from an exceptionally bizarre genetic disorder and has a congenital insensitivity to pain. Simply put, she can feel absolutely no pain whatsoever. The disorder is very dangerous because the inability to feel pain means that sufferers may not recognize a potentially deadly problem as the warning signs cannot be felt. As an infant, Ashlyn never cried. Then, at 8 months, her parent took her to the doctor for an irritated eye. Medical staff noticed that she had a corneal abrasion, which should have been very painful. That visit led to multiple tests, and almost 2 years later, they received a diagnosis. To this day, Ashlyn will still sometimes stick her hand in a pot of boiling water to fish out a dropped utensil, forgetting that it will cause her skin to burn even though she won't feel it. Serving as an inspiration, Ashlyn and her family have started Camp Painless But Hopeful, a camp designated to raise awareness and help families living with congenital insensitivity to pain.
On the other end of the spectrum, if you have constant daily pain, not only is the greatest tormentor, but it also kills your spirit.
One of the questions, has been, it's not so important to treat pain, it doesn't kill you. Well, in fact, John Libeskind, a very famous neurophysiologist and pain expert, did a series of experiments that basically demonstrated that pain could kill you, to the point that these animals stopped eating, stopped drinking, and basically died. This persistence of pain, these continuous painful stimuli to animals, caused them to withdraw from the group of animals, caused them to stop eating, caused them to stop walking about in their cages and withdrawing from their group. And so these are what we see in patients. They can't eat, they can't drink, they're in such severe pain, they wish to die. And then you relieve their pain, and they begin to look on life somewhat differently.
So what is pain? We'll know somehow along the way in our life, we somehow experience pain. But it's defined by the International Association for the Study of Pain is something very unpleasant. It has both physical, emotional component to the experience associated with actual. So if I burn your skin, you will have physical and emotional experience negatively, and resembling or actual or potential tissue damage. That means if I attempt to burn your skin again, it may be enough to elicit unpleasantness that has physical and emotional experience. If you remember in physiology, when you have noxious stimuli, you activate the nociceptors, and these nociceptors will travel via the C fibers and the A delta fibers. The A delta fibers is thinly myelinated, small but thinly myelinated, whereas the C fibers is small, it's unmyelinated. Meaning when you stimulate the A delta fibers, the conduction velocity is a bit faster. It crosses contralaterally to the spinothalamic tract and it ends in the thalamus. Whereas the C fibers, it's a bit slower because it has no myelin, and it also ends in the thalamus, which is a relay station. And from then, it goes to the parietal cortex, that's the cognitive component, and some fibers will also go to the limbic system, which is emotion. So emotion is always part of the experience. So you can see in this video, there's a varying degrees of emotional component with increasing intensity of the pain.
Charlie bit me. Ah! Ouch! Ouch! Ouch, Charlie! Ow! Charlie, that really hurts. No, Charlie bit me. And that really hurt, Charlie, and it's still hurting.
So you can see the C fiber is still firing. So the A delta is fast, discrete, highly localized, and the C fibers, it's slow and it lasts longer. And he said still hurting. Well, but unfortunately, life is not as simple as that. So there's also at the same time this modulation from the higher center, from the hypothalamus to the periaqueductal gray, the midbrain to the RVM medulla and raphe nucleus, and it constantly modulates the dorsal horn of the spinal cord. So we have patients who can actually increase the modulation from the higher center. That's why they can walk on fire. I'm not saying that you should try this, but this is something that can be done in some exceptional patients. So I try to make my life very simple. If I see patient pain, I think about two things. Am I dealing with nociceptive pain, meaning is damage to body tissues like musculoskeletal? Good example is pain secondary to a fractured limb. So that's a very typical example of nociceptive pain. On the other hand, if it's neuropathic pain, this is caused by lesions or dysfunction to the somatosensory nervous system. So it can be post-herpetic neuralgia, trigeminal neuralgia, painful diabetic neuropathy. And the reason we like to differentiate the two is that pain medication that works well for nociceptive pain may not work well on neuropathic pain. On the other hand, medication that works very well on neuropathic pain may not work well on nociceptive pain. So that means you need to really differentiate between nociceptive and neuropathic pain. But in the real world, it's not black and white. Sometimes we have a gray zone area. So we have a mixed pain, meaning they have a component of neuropathic pain and at the same time they have a component of nociceptive pain. Typical example are most patients with cancer-related pain. So up to 40 to 50% of patients with cancer-related pain may have a component of neuropathic pain component, meaning that you not only use medication that works well for nociceptive pain, then you may have to use medication that works well for neuropathic pain as well. So this is a very typical example of nociceptive pain. There's a lot of inflammations, there's tophi. So this patient works, they respond very well to anti-inflammatory.
The first time that you saw me, the pain is all over. It's so lacerating and tearing. And that sometimes I cannot bear the pain. Whenever I move, it's become painful. It does not affect my sleep. I sleep, but not sufficient enough. Because whenever there is pain, I wake up. It's bearable, except on this other part that it's very painful. Here, the moderating, tearing, with the cutting, but by and large, it is improving. Last time, it's so painful. It's penetrating, it's lacerating all over, and it's very painful in my head. But now it's okay.
Okay, so he's a lawyer. He's not a doctor, but he comes up with terminologies like moderating, penetrating. So that's a problem with neuropathic pain. We're lucky in this patient, we're able to see the lesions along the P4 dermatome. But if there's no lesions, then you may have to have a hard time dealing with this patient because there's the challenge here is to describe their pain for the clinician to understand that there's, dealing with neuropathic pain. So these are screening instruments that you can use to detect patients with possible neuropathic pain. And some of these, you don't really need to do neurologic exams. So for example, NPQ, pain detect, or ID pain, you don't need to do examination. So it's a self-answered questionnaires, and it can help you determine if this is neuropathic pain or not. So I will channel you to Google search regarding this screening instrument. So this is a very good example of mixed pain. So this is amputation, so they have nociceptive, and eventually there will be a phantom limb pain because you cut on the nerve, and very challenging to treat. So how do you assess pain? This is self-explanatory onset. So it's either acute or chronic, location, duration. The characteristic of the pain is very important. Again, it gives you an idea if it's neuropathic pain or if it's of nociceptive pain. I think very important here is the pharmacologic treatment history. So because that can guide you regarding the dose and what medication that you can try if the patient's pain is not well controlled. So how do you measure intensity of pain? Unfortunately, unlike fever where you have a thermometer or blood pressure, there's no instrument that can detect the intensity of pain. So you may have to report, you may have to really learn to trust your patient's feedback. So because it's a subjective experience. So these are unidimensional scale. So one is the numerical scale 0 to 10. 0 is no pain, 10 is the worst pain, and you can use the FACES pain rating scale. It's very effective in children as young as 3 years old. You can have visual analog scale, which is being used in most clinical research, categorical scale. So you can use this, So in essence, the secret here is to learn to believe your patient. So we have a patient who, after 18 months of saying he has a lot of pain, nobody believes him until someone did an X-ray and found out there's an instrument that was left behind in the operative site. So you can also do a multiple dimensional instrument. This is very good in major pain clinics. So not only measuring the pain intensity, but looking at the quality issue of life. For example, mood, relationship, sleep pattern, enjoyment of life. Because in reality, you really have to focus on the biopsychosocial model of pain. And I'm really glad that we have members of our psychiatry here who can do a lot of psychological assessment and even social assessment. Clearly, if patient is depressed, or clearly if patient is anxious, or who just got fired from his job, the intensity of pain is worse than those with good family support, good economic support, so on down the line. For the pharmacologic management, these slides will tell us in summary how to give analgesia in patient pain. So you focus on the pathways of pain. So if you have you can use non-steroidals or COX-2 in the periphery, so that's transduction. You can use local anesthetic to prevent conduction. You can increase modulation from the higher center by using gabapentinoid or SNRIs or tricyclic antidepressant, and you can use opiates in this part. And in other words, you can employ different drugs with different mechanisms. So it has to be logical. So maybe it's more logical to use one NSAIDs and maybe medications that increase modulation, but it's not logical if you use 2 or 3 NSAIDs at the same time, because the mechanism of actions is identical. So I will just go straight to this very famous ladder, the WHO analgesic ladder. It's a 3-step ladder. When the pain is mild, then you can use non-opioid analgesics, for example, paracetamol, non-steroidal or COX-2 plus adjuvant analgesics. If the pain is moderate, then you may have to use tramadol and codeine, which is opioids for mild pain, for moderate pain. And then if it's severe pain, then use stronger opioids like morphine, oxycodone, or fentanyl. Many experts now questions the validity of step 2, because there's really no head-to-head comparison between step 2 and step 1. So it has not been found that step 2 is superior than step 1. In our clinical setting, especially in cancer patients, most patients are stuck, or doctors stuck in step 2. They never really get to step 3. So the NCCN guideline now change the 3-step ladder to 2-step ladder, meaning either you use non-opiates for mild pain or you give opiates for moderate to severe pain. So straight go to the point. This is the most stigmatized medication of all time. This is the most feared medication of all time, and this is opioids. And they classify opioids based on the receptors. So we have the mu receptor, we have the delta receptors, we have the kappa receptors, but it depends on the actions of the opiates to the mu receptor. So you can have pure mu agonists. So in these cartoons, you can see it fits nicely into the receptor and activates it. Typical example is morphine, oxycodone, fentanyl. And there's a partial agonist. That means it fits nearly into the receptor site, but not quite as well as the full agonist. So one is buprenorphine. The only drawback with partial agonist, there's a ceiling, meaning there's a maximum dose you can give, whereas the pure agonist, as they said, it can go as high as the sky. There's a mixed agonist antagonist, meaning they're antagonists to the mu receptor, but they are agonists to the kappa receptor. And this, in essence, you cannot combine mixed agonist antagonist with pure agonist, because you can potentially precipitate a withdrawal, because the mixed agonist antagonist is antagonistic to the mu receptor. And then lastly, we have the opioid antagonist. That means it fits in the receptor site, but it's not the right shape to activate it. One example is naloxone or naltrexone. This is the antidote, because the affinity of this medication to the opioid receptor is higher than opiates. So very quickly, because we don't have enough time, talk about salient points. Morphine is the standard. When we talk about opiates, the standard opiates, because it's widely available, it's oral, it's cheap, blah, blah, blah. But the only drawback here, it has active metabolites, the M6G and M3G, which can accumulate in patients with renal problems. So it can cause neurotoxicity. So be careful if patient has renal compromise. Oxycodone is a better drug compared to morphine. It has metabolites, but it doesn't contribute significantly in clinical practice. It's partially dialysable, meaning you don't need to adjust unless the creatinine clearance is less than 60 ml per minute. Fentanyl is a very strong opioid. It's about 100 times stronger than morphine. It's a very lipophilic, meaning you can give it sublingually, transdermally, IV. It doesn't have any active metabolites. A little bit expensive compared to morphine. Tramadol, in the past, many doctors believe that it's an anti-inflammatory, but in reality, it's a weak opioid. It has dual action. It binds to the opioid receptor weakly, but its active metabolites, the desmethyl tramadol, has a bit stronger than the parent compound. At the same time, it also acts as a serotonin and norepinephrine reuptake inhibitor. It's almost like SNRI. So be careful when you combine this on patient on antidepressant, because you can potentially precipitate serotonin syndrome or even seizure. So these are descending orders of opioid adverse effects. So the most common is nausea, constipation, somnolence, dizziness, dry itchiness, pruritus because of the release of histamine, and maybe vomiting. But mind you, you develop tolerance very rapidly to these opioid adverse effects. So that means the longer they are in opioids, the less is the side effects the patient will encounter. So the only side effects that you don't develop tolerance is constipation. So the patient will always be constipated. So when you have patient opioids, you are obligated to use some bowel regimen. So this is the most dreaded complications that we can think about when we talk about opioids. In medical school, our professor will really emphasize this, that the patient will stop breathing, so it affects respiratory rate, minute volume, oxygen saturations. In other words, but this should be in the setting that the patient is sedated. If the patient is not sedated, it's almost impossible that the respiratory depression is related to opioids. I have been in practice for the last 23 years or 24 years. I can count with one hand where I can honestly say it's from opioids. One is the patient was taking benzodiazepine on the side without us knowing, so the patient was sedated, and the other one is where the pharmacy made wrongly when they compounded the medication, the concentration was different from our order, so we have to give naloxone on this patient. So in other words, it's not very common. When you give opioids to patient in pain, it's different when you give opioids to patient not in pain, because pain is the natural antagonist to the respiratory depressive effects of opioids. But I like to emphasize this term opiophobia. That means underprescribing of opioids because of the overestimation of the potential for patients to become addicted to the medications. So they did a study right after medical school, and they did a survey, and they found out that after graduation from medical school, 40% of these medical students were opiophobic. And they followed this medical student who went to different specialty, residency, blah, blah, blah. After 4 to 5 years, 60% become more opiophobic. So that means we we as a consultant, we as a doctor, we reinforce how we train the doctors during the residency program. And amazingly, it's increased among surgeons and anesthesiologists, when in fact these are the very people who are responsible for most of acute pain in hospital setting. And it's decreased among radiologists who don't have really patient contact so much, psychiatrists and pediatrics. They did a similar study in Texas. These are practicing doctors, again, highest among surgeons and anesthesiologists. And opiophobia is least among psychiatrists and oncologists. And most of the fear is related to regulatory, the fear of the patient might become addicted or malpractice concern. I have a patient upstairs in Makati Meds. He's like 90 years old. He fractured his limb and he's scared that, if I give opioids, he might become addicted. So I'll segue to palliative care, the second half. And I remember many years ago when I did my fellowship at Memorial Sloan for pain, they introduced palliative care in the program. And at that time, I have no idea what palliative care is all about. So in that era, or, the concept of palliative care is like, you're going to die. Of course, that has evolved over time. So I remember when we have referrals of patients in pain and stage 4, we don't introduce ourselves as from the palliative care. We say we are from the pain service, and that seems to be acceptable. In Johns Hopkins Hospital, they when they launched the palliative care program, they seldom get referral until they change it to supportive care. So sometimes terminologies, you have to play around for consultants and patients to be more accepting. So this is the definition of palliative care by the WHO. So it's really approach to care that improves, it's the quality of life. So meaning quality of life of patients and their families, so patient and their families, to treatment of pain and other physical, psychological, and spiritual problems. So in the past, this is the paradigm when you're diagnosed with malignancy, for example, there's focus on curative intent up to the end. So we have patients who get chemotherapy and the next day they die. And then after, if everything is exhausted, then they go channel to end of life care. So there's a lot of abandonment, there's a lot of resentment, there's a lot of betrayal from the patient's part. And it's kind of it's not a good situations. But now they felt that palliative or supportive care should be introduced at the beginning of the diagnosis, so that the patient can avail of the psychological counseling or nutritional services. Fatigue management is very common in malignancy, rehabilitation, and of course, pain management. And this will be enhanced and intensified as the disease progress, and then seamless transition to end of life care. And that's the best quality of patients we can do on patient with life-threatening disease. So this is a landmark study. This was published in New England Journal of Medicine in 2010, that early palliative care for patients with metastatic non-small cell CA, they found out that patient has better quality of life, fewer depressive symptoms, less aggressive treatment at the end of the day, and most importantly, they live longer by 3 months. So for patients and family, that's very significant. 3 months may sound so short, but it can be very meaningful for the family. So they did a similar study, another study where early versus delayed referral to palliative care. The result is almost similar. There's 15% improvement in 1 year survival in patients with advanced cancer with mixed diagnosis. So again, good pain management means patient live longer. This is a guru from India. He's a yogi. He has a book on death, and he said, I don't know how many children you're gonna have. I don't know if they're gonna be successful or how much money they will earn. But I can tell you that someday you will die. And in essence, it's really more like, all of us will die, and as long as you're aware that you will die, then you will live everyday life. You will treasure living. So this is the trajectory. So when we talk about trajectory, is how the journey towards life. So unfortunately, that's our journey in life, whether you like it or not. That's our trajectory. So when we have malignancy, the trajectory towards death is a bit slow, but you know, but it if you step backwards, it's a really downhill course. If you have sudden cardiac arrest or massive stroke, your trajectory towards death is very fast. It's very important because you can you can prepare the family and the patient, and this is what you call advanced planning, and then ultimately to advanced directive. Sometimes patient gets referred to palliative care too little, too late, and we never really get a chance to prepare the patient and family for the eventual, death. So this is a quality of death index that was, they did a survey of 80 countries, how you take care of a dying patient. And out of 80, we're number 78. That's not good, right? So it seems that Nigeria is doing better than us, even it is doing better than us. So Ethiopia is better than us. So it means that, we're doing miserably. But of course, there's so many experts doesn't believe this survey, but nevertheless, it's nice to know that we score very badly in the palliative aspect. We score badly in human resources, affordability, the quality of care, and community engagement. So there's a textbook that was published in 2015, Palliative Nursing, for which I was able to contribute a chapter in this textbook, Palliative Care in the Philippines, and I can tell you in one sense, there's really nothing much to say. Okay, so there's so much improvement that we can do to our palliative care program. So what's the most frequently reported symptoms among patients with cancer? So of course, number one is pain and fatigue, and then descending order. And what's the most distressing symptoms? Again, pain and fatigue. So we have obligations to control this, because that will make the quality of life of the dying patient more bearable. So I like to touch on this topic because it's very important. The feeling of breathlessness. So normally us in this room, we are not aware that we're breathing. So we have this spontaneous breathing. But the moment you're aware that's a need for you to breathe, that's the beginning of what you call dyspnea, or in layman's term is air hunger. So unpleasant, uncomfortable awareness of the need to breathe. And trust me, you can tolerate pain, but you cannot tolerate when you're running out of air. And that's the worst exit. So we have obligations to control and to support patients who's dying of breathlessness, because especially those with patients with malignancy or involvement in the lungs, they get so breathless. And the etiology may be varied. It can be related to cancer. It may be indirectly related to cancer itself, or to the treatment, or even unrelated to the treatment. So it varies. Of course, the treatment is you focus. The treatment is you try to, if you can reverse the etiology, but most of the time you can't. And there's a pharmacologic management and non-pharmacologic management for symptomatic therapy. And if you look at the American Thoracic Guidelines, Society Guidelines, their first-line agent of choice for pharmacologic treatment is opioids. Again, if you look at the NCCN guidelines, it's still opioids. So that's contrary to what we believe, that you give opioids to for breathlessness. As a matter of fact, in medical school we were taught that opioids can cause respiratory depression. So there are so many mechanisms why opioids works in alleviating air hunger, but I can just tell you that the dose is much smaller than analgesic dose. So mostly it's related to cortical sedation, suppression of the respiratory awareness. There's analgesia, it relaxes the patient, it vasodilates, it improves cardiac functions. Overall, my experience is very good. For those patients with air hunger, So at the end of the day, we aim for a good death, and we surveyed patients who was dying, and we asked them, how would you like to die? And most patients would say, I would like to die, doc, in my sleep, in my own bed, and I want to die surrounded by my loved ones. So we aim for a good death because that's reality. All of us will eventually go that way. So freedom from distress and suffering for patients and family and caregivers, in general accord with the patients and families' wishes. So advanced directive, advanced care plan is very important, consistent with clinical, cultural, and ethical standards. So in other countries, they do physician-assisted, suicide, and which we don't do that here. But we have obligations to control and help patients who's dying. So I always wonder what it's like to die in the future. But amazingly, in China, they're so progressive that their death there is different. So I like to show you this slide.
对不起，我们尽力了。不过有个好消息也告诉你们，现代医学技术很发达，我们使用最新的高科技，将你老公大脑里的意识数字化，完整的转移出来。也就是说，你老公其实还活着。
你是啥？ 老公，
今后你们一定要好好的活下去啊！
谢谢你，医生，谢谢。老公，你现在感觉怎么样呀？
挺好的，感觉很轻松，人也比过去精神多了。
那你想吃点什么？我给你买。
其实只要充电就行了。
XR 手机双。Yeah, thank you very much. Thank you.
Thank you very much, Dr. Lu, for providing us a more in-depth understanding of pain. So echoing what Dr. Lu said, pain is not always negative, but it could be protective. So from Dr. Lu's lecture, we learned that there are many tools, which include the scales, and in our practice, the biopsychosocial model that can help us better assess and treat pain. We also gain a better understanding of palliative care, which again is not always negative, but in a way it could be restorative, not only to the patient, but also to the patient's family. If you have any questions for Dr. Lu regarding his lecture, please use the Q&A box to type in your queries, and our speakers will be addressing them later during our open forum. Before we proceed with the next lecture, we would like to thank our major sponsors for today: Otsuka Pharmaceuticals Incorporated, Conjugate Corporation Philippines, and Torrent Pharmaceuticals. We would also like to thank Medichem Pharmaceuticals Incorporated for graciously providing us for today's accommodation for this event. Our next speaker is one of the esteemed psychiatrists in our section, Dr. Rene Samaniego. He graduated with a Bachelor of Science in Psychology from the Far Eastern University and took up medicine in the same institution. He then had his residency training in psychiatry in Makati Medical Center and further trained in cognitive behavioral therapy in the United States. He is a psychotherapist, well-versed in Jungian psychology, and was a former member of the Washington Society for Jungian Psychology. He is a former president of the PPA, past president of the Carl Jung Circle Center, and is currently practicing as a consultant at the Makati Medical Center section of psychiatry. Let us kindly welcome Dr. Rene Samaniego.
Good morning, everybody. First of all, I just want to congratulate the organizers of this year's postgraduate course and webinar series on mental health. And thank you as well for inviting me to be one of the resource presenters. So for my bit, what I will be sharing with our listeners for this morning's session is a specific psychological approach or strategy, and that approach is called CBT, or Cognitive Behavioral Therapy. And as an aside, I just want to say that incidentally, Dr. Henry Liu, who is our other resource speaker for this morning, we were actually classmates in a cognitive behavioral therapy for pain workshop, which took place quite a few years back. So that was facilitated by the University of Sydney Pain Management and Research Center, which has a program called the ADAPT program, which is an intensive 3-week program wherein patients with problematic chronic pain would attend whole-day sessions facilitated by a multidisciplinary team of the center. And I will elaborate on this later on. But in a nutshell, the research has consistently shown that the methods taught in that program were more effective than just going for medications and passive treatments alone. So for the patients and participants of the ADAPT program, it translated to them experiencing much less troubling pain. They also had improved mood and confidence. They began to adopt better and healthier lifestyles. And overall, they had much less use of their pain medications. And an important aspect of this ADAPT program is the psychological and psychosocial management of the pain, which is centered on cognitive behavioral therapy, or CBT. And that is what I'm going to elaborate on for this morning. So CBT, by the way, is also the main model or framework that I adopt in my psychotherapeutic practice. So what do we know about CBT and pain so far? First, we do know that as much as 15% of individuals who struggle with chronic pain, maybe even higher, are more likely to have depression, anxiety, trouble in their relationships, or would even be out of work or non-functional. And about 50% of them, and again, the estimates can vary on this, are only able to get partial relief from pain medications, if at all. We also know that pain is a biopsychosocial phenomenon, which means that aside from the biological aspect of the pain, we also know that the perception of one's pain has a lot to do with how the person experiences the pain and copes with it. And because it is biopsychosocial in nature, then the best treatment approaches will always be multidisciplinary and or interdisciplinary. So aside from the main attending physician doing the pain management, they may also do complementary physical therapy and see a CBT therapist at the same time. So for instance, in the ADAPT program, they have the main attending doctor, they have a psychiatrist or psychologist on board, a physiotherapist, and a nurse. And for purposes of classification, though, I think it is worth mentioning that there are actually two categories of pain, one of which is acute pain, which is usually short-term. Oftentimes, it only lasts for seconds to hours, or occasionally maybe a few days or a few weeks. And it is usually a warning signal, which tells us that something is acutely wrong with our body. So for instance, when a part of our body is injured, like when you slip and fall and you fracture a bone in a body, fracture a bone in your body, you will inevitably experience acute pain. Now, chronic pain, on the other hand, is when pain persists for longer than expected. And a typical history of people who have chronic pain is either they sustain an injury and or undergo surgery for that injury, but for some reason, the pain associated with that injury or surgery, even though it has improved, never really goes away. So even though healing has been completed, the pain still persists. And that's why chronic pain is also referred to at times as persisting pain. So it usually involves the individual having pain on most days for longer than 3 months. So 3 months is the time specifier that IASP has set. So IASP stands for the International Association for the Study of Pain. Although there are some resources which defines it as longer than 3 months, like some says 6 months or even longer. But whether it's 3 or 6 months, the catch here is that the reason or cause of chronic pain is usually not fully understood. So some say that it is due to certain neuropathic mechanisms or certain activities in the nerve, which happens after an acute injury and or its associated surgery, which then leads to what we refer to as a quote-unquote memory of the pain, manifesting as continuous irritation and sensitivity. So you can imagine having a sunburn where your skin is quite sensitive and becomes painful even at the slightest blowing of the wind, no? Or if your clothes come into contact with your skin. So it's something to that effect. Now, another catch here is that the treatments that work for acute pain often do not work for chronic pain. So resting or inactivity, the use of pain medications and passive physiotherapy methods like manipulation, electrical stimulation, hot and cold compress, or massage. While all of these may significantly help with acute pain, they usually do not relieve chronic pain, at least not completely and permanently. Therefore, the point is, if you're a person suffering from chronic or persisting pain, and if you have gone through almost the whole gamut of the available treatment options without full or permanent relief of the pain, then it really all boils down to the realistic and practical stance of learning to live with the pain. And this is where CBT, or cognitive behavioral therapy, can be helpful. And by the way, when I say learning to live with the pain, I do not mean just suffering the pain unnecessarily. No, so it's not about being passive or not doing anything about it at all. On the contrary, it means being able to manage it better than the way you have been managing it, so that as much as possible, at least, you can live your life the way you want to, despite the presence of the pain. So with regard to CBT-CP, or cognitive behavioral therapy for chronic pain, as we speak, now, there are actually quite a number of research already which have shown that CBT can be superior or at least equally as effective to other treatments, including pain medications. And if you look at the existing researches online, you will find that CBT has been studied for a variety of pain issues, such as chronic low back pain, fibromyalgia, rheumatoid arthritis, chronic fatigue syndrome, chronic musculoskeletal pain, or even non-specific chest pain. But just to give you a quick background about cognitive behavioral therapy, or CBT, it is actually a psychotherapeutic approach which deals with the dysfunctional thinking and behaviors of certain individuals with psychiatric or psychological problems. And for starters, the cognitive behavioral model hypothesizes that our emotions, our behavior, or even the way we feel physically, all of these are influenced by our thoughts or our perception of events. And that therefore, it is not only the situation itself that determines how we feel, but also how we interpret the situation. So as a general example, if you suddenly feel a twitch or slight pain in your chest, and you suddenly have a thought, what if I'm having a heart attack? How would you expect yourself to feel? So of course, you're going to panic, right? Or if not panic, at the very least, you're going to feel anxious. So with the thought, I might be having a heart attack, on the emotional level, it can make you feel anxious and panicky. On the physical level, you may actually start to experience physical symptoms like palpitations, hyperventilation, difficulty of breathing, lightheadedness. But that is because of what you think and because you misinterpreted the chest pain as a heart attack. And because of that, you insist on bringing yourself to the emergency department. But what if you're not actually having a heart attack? What if you felt was just something benign, like a benign muscular or nerve activity? And so that is the goal of cognitive behavioral therapy, or CBT, which is to modify or change these dysfunctional thoughts, or what we call cognitive distortions, with the expectation that as we do so, the symptom or symptoms will improve or is even resolved. So the way that CBT works for chronic pain is actually very similar to how it works for all the other psychiatric disorders like depression, anxiety, substance abuse, eating disorders, even schizophrenia or bipolar, or other psychological symptoms. And it centers on the idea that our thoughts, our feelings, and our behaviors are all intertwined. So imagine a triangle standing upright, and at the top portion of this triangle is our thoughts, whereas at the other two lower ends are our feelings and behaviors. And there's a bidirectional relationship among these factors. So if an individual has distressing thoughts, that can lead to distressing feelings, which then leads to behaviors that may not be helpful or effective. And that goes round and round as a vicious cycle. So specifically for patients who are consulting me for the very first time, but who have been dealing with chronic pain, by virtue of the course of their pain, which means that it's chronic, so meaning they have been suffering from pain for some time already. As expected, these patients have tried a lot of treatments already, and many of them haven't had much success with those treatments, which also means that I'm not the first doctor that they are consulting, nor the first modality that they're trying. So because of the chronicity of their conditions, these patients usually have existing thought patterns about pain already. And very common thoughts would include, this pain will be around forever, or there's nothing I can do to change this pain, or I'm helpless in the face of this pain, or if this pain keeps on going, there will just be further damage and I will never be able to recover from it. And these thoughts are what we refer to in CBT as automatic thoughts. So they're almost like habits that we have developed over time. And such thoughts can, of course, lead to feelings, which is another basic rule of CBT, like I mentioned earlier, which is that our feelings are a result of our thoughts. So if you have thoughts like, this pain will be around forever, or I will never be able to recover from this pain, how would you expect to feel? Logically, you may feel an increased sense of helplessness and frustration, or even anger, or depression, or anxiety. And while these feelings may not necessarily directly cause pain, they can certainly cause emotional and psychological distress, which increases the pain experience or the intensity at which the pain is felt, thereby increasing the patient's overall suffering in the process. So that is the cognitive and emotional part. Now, what happens at the behavioral level? So when we are experiencing pain, what is it that we would instinctively do? We would normally stop whatever it is we're doing and rest, right? So we would instinctively want to protect ourselves and guard ourselves from the pain. And so we're inclined to not move as much, rest more, immobilize our bodies, which then leads to another problem, which is the further deconditioning of the body. And of course, this deconditioning would lead to decreased functionality and increased sense of isolation. So ultimately, this makes the patient feel less in control and powerless over their situation. And that is basically the problematic vicious cycle that happens. So as a cognitive behavioral therapist, we intervene at the level of the patient's thoughts and behaviors and see if we can counteract and break the cycle to help the patient feel more confident in their ability to handle or manage the pain. So just to give you an example of a specific strategy, we have in CBTCP what we call a pain response diary, wherein we ask the patients to note down their pain levels whenever they're having a flare-up. So they can do it on a 0 to 10 scale, with 0 equals no pain and 10 equals the worst pain imaginable. So for example, in this slide, the patient notes that her pain level to be at a 7. Then we ask them to take note of their thoughts as they're experiencing the pain, which is actually the first and most important step in thought management, which is to identify your thoughts, specifically the catastrophic thoughts. And this is but logical, because you cannot change or modify something that you're not aware of. So again, with our patient here, she noted her automatic thoughts as, what's the use of trying when nothing works? And I cannot go on like this. So as a result, she feels hopelessness and desperation. And lastly, you may also want to take note of the situation. So for example, what were you doing at that time? Or where were you when you had a flare-up? And again, in the case of our patient here, she gets awakened by the pain at 2 in the morning. And equally important is that we need to teach and guide our patients on how to develop new cognitive, new and repeat. And equally important is that we need to teach and guide our patients on how to develop a new cognitive response to the original catastrophic thought. So, for instance, I have a patient not too long ago. She is in her early 60s who suffers from chronic pain, who simultaneously has panic disorder. And her main problem for the longest time is her fear of going out of the house. So her usual automatic thoughts would be, what if I worsen my pain by going out? Or what if I have a flare up when I'm out? And because she also has panic disorder, she would also think, what if I have a panic attack because I'm unable to handle the intensity of my pain? So those were her original catastrophic beliefs and predictions, which in fact are very typical among patients who suffer from chronic pain. And those are the anticipatory anxieties that we work with and challenge in CBT. So for this patient of mine, we started out with a behavioral experiment of going to the mall. So I asked her to choose a mall that was nearest to their house so that she's able to do away with the stress of the long travel. And then she herself thought of the idea of going first thing in the morning. So she said, what if I go first thing in the morning so that it's not that crowded and I can just leisurely go around the mall or the place? And on top of that, I also suggested that she goes with their helper, hoping that it would somehow make her feel more secure, should anything happen while she is there. So, of course, as expected, she was quite anxious about the idea, but she said that she was willing to give it a try. And so she did. And of course, as expected, again, there was pain when she went out, which was in fact slightly more intense than her usual. But interestingly enough, now when we had our follow-up online session, she reported that she realized that most of her catastrophic predictions and expectations were not true or did not come true. So yes, there was actually more pain, but it did not go up to the extent that she thought it would, meaning it wasn't so severe that she was not able to tolerate and handle the pain. And in fact, she said that after she did the behavioral experiment, she actually felt a boost in her mood and in her energy. Because even if she was anxious, she also felt excited about being back in the grocery store. And that's after a while of going there, because she used to love grocery shopping. And she also did not have a full-blown panic attack, by the way, as she was expecting. So in a nutshell, it's important for us to listen closely to our patients' beliefs about their pain and what that means for them. Because oftentimes their predictions and automatic thoughts about their pain are either not true or at least not 100% true. The goal, therefore, is to first identify the original catastrophic patterns of thinking, which oftentimes look something like this. So whenever patients start feeling the pain, they would begin worrying and having thoughts like, oh no, here it is again, what if it gets worse? And because of this overthinking, they may also have the tendency to focus on the unpleasant emotions that they're feeling, and subsequently start to think and feel that they're losing control of the situation, which of course would lead them to a state of anxiety or even panic. This will then lead them to habitually withdraw and avoid a lot of their activities of daily living, and more losing their confidence over time. So we would want to challenge this vicious cycle and aim for or turn it into something like this. So instead of worrying and overthinking, you may just want to simply recognize what is happening in the moment and keep calm. So instead of thinking, what if this gets worse? You may want to tell yourself, okay, I'm having a flare up and experiencing pain right now, and it may be bad for a while, but I can get through this. Now, just like in the past, I've gotten through all of the flare ups that I've had. And instead of focusing on your unpleasant feelings and the thought that you have no control over the situation, you need to shift gears from worrying to strategizing, meaning you need to recognize that, okay, the reality now is that I'm having a flare up, but what can I do to take care of myself because I am in pain? So you can probably stop whatever it is you're doing and rest for or sleep for a while if the pain is intense. And or if not, you may even want to challenge it a bit, no? And maybe do some gentle stretching exercises while you're laying in bed, or even go for a brief walk to distract yourself from the pain. So what I'm talking about now is actually a formal mindfulness exercise called mindful self-compassion, which involves a simple two-step process. The first of which is to recognize, not to be aware that we are in a moment of suffering. And this suffering does not have to be limited to physical pain, but it can also apply to emotional or psychological pain. So when we are feeling sad or anxious or stressed or overwhelmed or frustrated or even angry, so these are all examples of moments of suffering. And the next equally important step after recognizing that we are in a moment of suffering is to ask ourselves, now what do I do? Or how do I take care of myself in the midst of this suffering? Now, because I think the second step is something that we often take for granted. And we often just get stuck in the first step without doing anything about it, which is that we just recognize that we are suffering or we are in pain. So if we're able to apply these cognitive strategies or exercises, I think that there will be an increased chance of success, that the patient will be able to manage the pain better, which eventually increases his or her confidence. And in the end, you also need to maybe mentally affirm yourself and validate your success. So maybe telling yourself something like, I think I did that well. No? So I now know better what to do next time. And most likely, I will be able to handle my future flare-ups better. So what we're doing here is we are trying to develop a new cognitive response whenever you're having an episode and replace the old catastrophic patterns of thinking. So, of course, aside from this strategy, there are a host of other strategies that we can share with our patients. So, for instance, in the ADAPT program, a practical but very important aspect of it is physical activity, which is exactly what chronic pain patients commonly avoid. But then, as I mentioned earlier, not doing physical activity would further lead to deconditioning, which means that even with mild exertion or effort, you may actually start to experience pain, which sets off again a vicious downward spiral of continuously decreasing activity and more pain over time. So inevitably, you really have to adopt an exercise program. And this may start with, very simple stretching exercises. And perhaps from there, you can transition to strengthening exercises, after which you can maybe attempt to move on to aerobic exercises if you can tolerate it at all. But the ultimate goal for you is to be able to slowly go back and perform again specific tasks that you have stopped doing because of the chronic pain. And of course, at the psychological level, as you start to feel stronger, you can also start to feel more in control. So your confidence may increase, thereby reducing your fear of doing such activities. And that is what we refer to as reversing the downward spiral and instead creating an upward spiral. So I also wanted to talk about pacing, which simply means that you have to start small, set a realistic goal that can easily be achieved, and doing a little bit more at a time as you go on. So in short, as you're attempting to challenge yourself, you should also not overdo things, because overdoing it can also aggravate the pain, which again may set off avoidant behaviors towards your activities. So we also have what we refer to as attentional techniques, which involves changing or modifying how much attention you give to the pain. And a very common example of this attentional technique we do in CBT is the distraction technique, which simply involves focusing your attention away from the pain. And while you're doing that, you may actually simultaneously practice some exercises like visual imagery. So how you do this is you can visualize a pleasant or relaxing scene, such as the seaside. You can focus on the colors around you, the sound of the water, the warmth of the sand under your feet. So by involving all of your senses in the imagery exercise, it actually makes it easier for you to moderate the sensation of the pain because you're focusing on something else. Again, I want to stress not to eliminate it completely, but at the very least, make it more manageable. So on the other hand, there's also this interesting CBT approach to chronic pain, wherein alternatively, you may actually choose to intentionally focus on the pain instead of distracting yourself away from it. And this is a strategy we call desensitization technique, wherein whenever the patient is experiencing pain, he or she intentionally focuses on it. But at the same time, mentally telling oneself neutral statements like, I'm not in any imminent danger, or I'm just experiencing pain and it is neither good nor bad, or it is what it is and I'm okay. So by doing that, you're not instinctively avoiding the pain because realistically, there will actually be times anyways. Now, there will also be times when you won't be able to change the intensity of the pain. But what you can try to change is how you relate to the pain or how you think about it and how you handle or manage it. So in the ADAPT program, when the participants do this consistently, they find that the pain does not bother them as much. So in conclusion, CBTCP, or cognitive behavioral therapy for chronic pain, is essentially and practically self-management, because the ultimate goal of CBT anyways is to make the patient his or her own therapist. So we discourage overdependence and instead encourage self-sufficiency. And that's also the reason why CBT is often time limited. No? So usually it lasts for a minimum of only around 12 sessions or sometimes a maximum of 21 sessions. So compared to other longer term therapies like psychodynamic therapy. So lastly, in CBT-CP, we give emphasis on how to function and live with the pain, as I mentioned earlier. And we do this mainly by cognitive strategies, which involves identifying the patient's catastrophic beliefs and expectations and working on them and modifying them. Simultaneously, we also employ behavioral strategies, and this is where physical activity, pacing, attentional techniques, and desensitization will come in. And lastly, let us remember that by itself, pain does not have to make us unhappy, frustrated, irritable, and all the other negative feelings that often go with the pain. How much pain affects us and what we do is strongly influenced by the ways we think about it. But more importantly, our thoughts can be under our control, so we can choose how we think. We might get into habitual ways of thinking at times, and we may feel we have no choice, but we can always change our minds. So remember that as above, so below, and as within, so without. And lastly, I'd like to leave you with this quote from the British philosopher James Allen, lifted from his classic self-help book, As a Man Thinketh, which goes, "You are today where your thoughts have brought you, and you will be tomorrow where your thoughts will take you." So with that, thank you for your attention.
Thank you, Dr. Samaniego, for showing us the connection between the way we think and the way we perceive pain. Truly, this would help us to be more holistic in treating our patients with chronic pain. We learned today that how cognitive therapy can benefit those patients with chronic pain. In management of chronic pain, we must consider the emotional and cognitive factors that ultimately affect one's behavior and perception of pain. So before we proceed to our open forum, we will have a 10-minute break. Kindly input your questions on the Q&A box, and our speakers will be addressing these questions during the open forum. Now we will be hearing from our pharmaceutical sponsors for the day: Otsuka Pharmaceutical Incorporated, Conjugate Corporation Philippines, and Torrent Pharmaceuticals. Again, we would like to thank Medicam Pharmaceuticals Incorporated for graciously providing us today's accommodation for this event. Thank you once again to our major sponsors for the day: Otsuka Pharmaceutical Incorporated, Conjugate Corporation Philippines, and Torrent Pharmaceuticals. Before we proceed to the open forum, may we gently remind everyone to answer our evaluation form for this event. You will be seeing a pop-up on your screens, and just click the link which would lead you to the form. We will be sending this prompt again later after our open forum. This link will also be posted on our Facebook page, Makati Med Psychiatry. So again, good morning, doctors. Thank you for joining us for the open forum. We have received several questions from our audience. So we will begin. So the following questions are for both Dr. Lu and Dr. Samaniego. So for the first question, is forcing yourself to ignore the psychological pain a good coping mechanism, or not addressing it can make it worse? I think Dr. Samaniego, would you like to answer this question first?
Sure. Good morning, everyone.
Morning, doctor.
So if we go back to my presentation, I actually mentioned two specific strategies, one of which is the attentional technique, which involves changing or modifying how much attention a patient gives to the pain. And an example of that attentional technique we do in CBT is the distraction technique. So very much so, distracting our focus away from the pain can be beneficial. So it involves focusing our attention away from the pain. And while we're doing that, we may also do what we refer to as visual imagery exercises. I also explained that in my presentation. So you can visualize perhaps a pleasant or relaxing scene, such as the seaside, focusing on the colors around you. Feel listen to the sound of the water, feel the warmth of the sand under your feet. So what happens here is when you involve all of your senses in the imagery exercise, it actually makes it easier for the individual or the patient to moderate the sensation of pain. So again, I just want to highlight, not to eliminate it completely, but at least to make it more manageable.
Thank you, doctor. Maybe hear from Dr. Lu.
I have nothing to. I leave it to Rene. He's the expert on cognitive behavioral therapy. Yeah.
All right, doctor. We have a question actually again for Dr. Lu. So the question states: some pain medications are known to create dependence and at the time psychosis after prolonged use. May we know, doctor, what your comments on this are?
Well, these are very blunt statement. It's a topic by itself. There's a textbook about this, how to deal patients with substance abuse, and we have to be very careful with terminologies because we could be victimizing victims second times, three times. We could be stigmatizing patient, labeling them. You have to define terms. What is dependency? and what is addiction. So if you're really going deeper with psychiatry, if you're on benzodiazepines, or if you're on steroids, or even if you're on antihypertensive medicine, you will be dependent. Now, so this is a pharmacologic property of the drugs. Addiction is something else. It's more of psychological. So it's the need to use the medicine for psychological, effects. But that's again very, very, very vague, and we need to define fine lines, because the last thing you want is to victimize patient who has really in pain and you label them as addiction. In reality, we are very, very good in labeling patients addict, but we have no idea. We're not an expert. And in reality, pseudo addiction is very common. This is behaviors that typifies addictions, but actually these are pain driven. If you're in pain, I give you paracetamol. If you have cancer pain and I just give you mild dose of, biogesic, you will have behaviors that you think typifies addiction. You will go doctors hopping and you go force prescription because these are pain driven. So that's what you call pseudo addiction. The best treatment there is to give them the right medicine and the right dose, and believe your patient. Dependency is a very touchy issue, and I have been in practice for like 23 years. Yeah, you can smell them. I mean, but you really have to be very, very discreet. I mean, cancer patients, you throw that out in the window. It's smooth and academic. So it's a one chapter. It's actually a textbook on substance abuse, and there's no way of finding out what's real. So there's a behavior. There's are behaviors that typifies that predict that this patient will most likely are substance abuser. There are behaviors that predicts less likely that that this patient is a substance abuser. For example, if the patient injecting oral medications, that's more or less, that this is really psychological dependency or addiction. But if the patient increase the dose without your concern, or you're going to see another doctors, that's not addiction per se. Yeah. Okay.
Thank you, Doctor. Another question for Dr. Lu. In your practice po, Doctor, is it usual to have a psychiatric disorder when you have a patient diagnosed with fibromyalgia?
Yeah, we have a webinar next month, November 11, I think November 10. We have an expert in fibromyalgia from University of Toronto. So I'd like to invite you. I'll put the link later on. So we will learn a lot together regarding fibromyalgia. It's very controversial topic. There are countries that identify fibromyalgia as real. As a matter of fact, they get welfare reimbursement from the state. So yes, if you look at the picture, I show you the pathways of pain, and emotion is part of the totality of the experience. And of course, if you're in pain all the time, every day in your life for maybe the last 3 to 4 years, you tell me if you will not have psychiatric problem. So this is something that we really need to expand. And let's learn together. Webinar series on fibromyalgia, I think it's November 11th. So that will be next month. So let's learn together on fibromyalgia. Good thing about fibromyalgia is that they found out that there's increase in the level of, I think it's CGRP. So more or less, if you check the blood level of CGRP, most of these are increased. Who are these patients who get fibromyalgia? I have no idea, but it seems that the theory now is there's internal sensitization. So the brain is like sensitizing itself, that they will have increased lower threshold of pain. And, it's a difficult patient. It's really difficult patient to treat. And I would love to refer this patient to somebody.
Thank you, Doctor. We'll make sure for Doctor to attend the
I'll send you
discussion.
the link. Yeah, I'll send you the link when we have the link later.
Thank you. For our next question, it is for Dr. Samaniego. There was a question I would like to ask ask if after CBT management for patients suffering from chronic pain, do you continue medication such as analgesics or psychotropics, or may that be discontinued after the patient has developed adaptive core beliefs and coping strategies, such as the case you presented po, doctor, of the 62-year-old female?
So I think my response to that would be it will be on a case-to-case basis. So depending on how the patient respond to both the medications and the psychological strategies. So for example, in my patient, I gave this patient of mine, since simultaneously she is also dealing with a panic disorder. So I opted to give an SNRI, which is an antidepressant that addresses both neurotransmitters serotonin and norepinephrine, both of which are again implicated in the pain pathway. So I had actually to go up to 90 milligrams per day, which is kind of an off-label dosing. But after 6 months, I was able to bring that back down to 60. And together with the psychological strategies, she actually continues to be okay. So experiencing much less anxiety now and able to cope with her pain much better.
Thank you po, Doctor. There is another question from the audience for Dr. Samaniego again. Is there a Philippine counterpart to the ADAPT program to help patients with chronic pain?
Unfortunately, we do not. No. It would usually happen informally, this multidisciplinary approach. So what would happen is I would get referrals from either neurologists or other specialists who are dealing with patients experiencing chronic pain. And by the time that they come to see me, they have already been referred to a physiotherapist. So with regard to that formal setup of the patients going to the hospital every day, because that's what happens in ADAPT program, it's a 3-week intensive program wherein the patients go to the hospital on a daily basis. So it's really, it's kind of a complex setup. No? I'm not so sure if Dr. Henry, you might be aware of a program existing in any of our other tertiary hospitals here in the Philippines. But as far as I'm aware of, I don't think we do have that.
Thank you po, Doctor. I guess both speakers can answer the question. There's another question. For patients with chronic pain, when do you recommend just pharmacologic intervention versus pharmacologic plus psychiatric intervention, which involve, for example, CBT? Dr. Samaniego, would you like to answer first?
Sure. So, because the general recommendation, if we're going to look at the evidence-based researches, the ideal approach for any psychiatric condition, and whether or not it is involving a comorbid medical condition, is really a combination of both medications and psychotherapy. So I think specifically in the case of patients experiencing chronic pain, or maybe I'd like to say patients who are experiencing or dealing with any chronic medical condition, whether pain-related or otherwise, like for example, hypertension, diabetes, asthma, gastrointestinal problems, or even dermatologic problems that have a chronic course, let us remember that there is such a thing as a psychological response to medical illness. So I guess depending on how problematic that psychological response is, such that patients can develop formal psychiatric problems like clinical depression or anxiety disorders. I think at the end of the day, any patient dealing with that condition can benefit from both. So my direct answer to that is I think both are imperative aspects of the management or the treatment.
Thank you po, Doctor. Maybe hear from Dr. Lu.
Especially those challenging one, it's always nice to have a multidisciplinary or interdisciplinary approach to this patient. So we, the help of our psychiatry friends or psychologists, because it's really important. Yeah. So we did that. Yeah.
Thank you, Doctor. Thank you, doctors, for answering our questions. Again, thank you, Dr. Lu and Dr. Samaniego, for the insightful discussion. We learned a lot from both of your lectures, po. So thank you everyone for attending day 3 of our webinar series on mental health entitled Bridging Mental Health, the Pursuit of Well-Being. Please don't forget to answer the evaluation form for this event. We hope to see you all again in the succeeding days. We will be using the same link for tomorrow's webinar. So simply click the link used to register and type in your emails in the login field to access our learning platform. Continue to stay safe, everyone, and see you again tomorrow for day 4. Also, the recording of yesterday's lectures are now uploaded in our YouTube link and our Facebook page, Makati Med Psychiatry. You may also see the links to the evaluation forms for the past lectures posted on our Facebook page. Again, thank you everyone and stay safe.
Thank you to our major sponsors: Conjugate Corporation, Distrafil, Distribution Solutions Philippines Incorporated, Johnson's & Johnson's Philippines, Lundbeck Philippines, MedChoice, CNS Pharma Group, Medicam, the CNS subsidiary of Unilab, Otsuka Pharmaceuticals, Torrent Pharma Philippines, we would also like to thank our minor sponsors:
Abbott Laboratories, Sun Pharma Philippines,
Zydus Neurosciences. Special thanks to Vexa Life Sciences. This event is powered by Beatrice,